Everybody, it's Dr. Eric Balcavage and Dr. Erica Riggleman. We're back for another edition of the Thyroid Answers Podcast, and we are filming live today.
Yes.
And we're next to each other versus just doing the computer.
So not hundreds of miles away.
I made the long road trip down to the Riggleman residence so we could shoot a live podcast. So that's what we're doing today.
Yeah. And today we are going to be talking all about reverse T3. We've gotten lots of questions from our listeners, and it's kind of a muddy water, if you will, in the thyroid realm of really what it does, how it affects thyroid physiology, the symptoms that can go with it, and what you can actually do to resolve some of the,
the elevations and the problems with it.
Exactly.
Absolutely. So we're going to go through some questions that we got. We're going to do our best to give you some concise answers, and they may be a little long-winded at times. It could probably be my fault.
We'll try to get scientific, but we'll also try to be very simplistic for people who may not know a lot about thyroid physiology. So why don't we just start out by answering the question of what is reverse T3?
You want me to take it?
Go ahead.
All right. So we have two primary hormones that the thyroid gland makes, T4 and T3. And the vast majority of what the thyroid gland makes is T4. It's a pre-hormone. It's not quite ready for prime time. It's more in an inactive state. And then that's kind of a loose term because it does have some functionality, but not for really cell metabolism like genomic, what we call regular cell metabolism that most people are thinking about. So T4, primary hormone that's made. Some of the tissues of the body require T4 to be converted to T3 because they can only use T3. So the T4 that's made, the vast majority or a large percentage of T4 is converted in the liver to T3 that circulates in the bloodstream, goes to the tissues that have to have T3. The rest of the cells of the body, and there's a whole bunch of cells in the body that really prefer to take in T4 and then convert T4 to either its more active state, T3, inside the cell, or deactivate T4 to something called reverse T3 inside the cell based on what's going on inside the cell. So if a cell wants to increase its metabolism, it converts T4 to T3, and that binds to the nucleus in your cells and stimulates your metabolism. But if a cell is trying to slow the metabolism down inside it, then it will deactivate T4 to something called reverse T3. And if the cell is deactivating T4 to reverse T3, it's also deactivating T3 inside the cell, but it's deactivating to something that we typically don't measure in a regular lab, in a clinical setting, which is something called T2. But they do use that in research when they're looking at what's happening to thyroid hormones. They are measuring and taking a look at T2. We just don't have that test available to us in a clinical setting. So reverse T3, we could say, is the deactivated form of T4.
Okay, that was a great explanation. I think one thing to point out about reverse T3, it may not even be something that you've even heard of because it's not often run by most primary cares or endocrinologists. So, that may be the first time you've ever even heard of reverse T3 or not even knowing what it actually is. The problem with reverse T3 is that the reason it's not run by maybe a primary care endocrinologist is because, a lot of times the insurance companies restrict what labs can be done. And then on the flip side of it, it isn't going to change the treatment options for most practitioners. If they have a high reverse T3, it's not going to change whether they're going to put you on a thyroid medication or not. They're going to be basing that mainly off of TSH.
TSH and T4. So when you see your primary care and you have hypothyroid symptoms, the primary thing that they're looking at is to see if the gland is still making sufficient levels of thyroid hormone. And as we talk about all the time on the podcast, hypothyroid symptoms are caused by what's happening within the cell. So if you don't have sufficient T3 inside your peripheral cells binding to the nucleus, you're going to have hypothyroid symptoms. It doesn't matter what your TSH is. It doesn't matter what your T4 or your T3 even in the blood. It's a matter of how much T3 that gets to the receptors of your cells. So if you're struggling with chronic hypothyroid symptoms, you're getting decreased T3 to the cells. But that is not really what's being looked at in traditional allopathic medicine. So they're waiting for TSH to rise out of lab range and T4 to drop below lab range. And as soon as TSH rises and T4 drops below lab range, then you're diagnosed with what we call primary hypothyroidism. The gland is not making sufficient hormone. And in that situation, the treatment then is to give enough T4 typically to bring TSH levels back to normal range and T4 back to normal blood range. And if those two things happen, that's the end of the story. They assume that as long as those two things come back into range, that everything is hunky-dory. You could still have hypothyroid symptoms, because the really important thing here from our standpoint in functional medicine, and for your standpoint as somebody who's struggling with chronic hypothyroid symptoms, what's happening to that T4 once it gets into the system? Allopathic medicine has kind of missed this step, in my opinion. That's where a lot of patients are failing in traditional allopathic thyroid care, is we're just assuming that TSH and T4 tell us what's happening in the peripheral cells. And as we've talked about many times, those two markers are not valid indicators of what's happening inside the cell. So your doc's not going to run it for insurance reasons. Your doc's also not going to run it because it doesn't do anything for them for a diagnosis, and they're not going to run it because it doesn't impact diagnosis and it doesn't impact treatment.
Exactly. So if you are going to your primary care to get your thyroid panel, you want to be specifically asking them to run that value. I think it's really, really important to have that evaluated, as well as the other values that we've always talked about on the podcast. But reverse T3 is an important marker that shouldn't be, overlooked.
And I think I think the other thing to go along with that, try and get them to run as much of the panel as you can get them to run. T4, TSH, T4, they'll probably always run that. They may run the free T4. A lot of docs rarely ever run T3 or free T3. We think those are important. Even T3 uptake is important, and thyroid antibody is important as well.
All of those markers. So there's a lot of theories when it comes to reverse T3 and what it actually does to thyroid physiology. What do you think about the theory that reverse T3 blocks the receptors?
So this is something that I know we were both taught when we were studying thyroid physiology, that when you convert T4 to reverse T3, that actually blocks T3 from binding to the receptor, and that causes hypothyroid symptoms. And I've scoured the literature. I'm a research nerd, and I've read hundreds and hundreds and hundreds of papers on thyroid physiology, and I have not been able to find anywhere where reverse T3 actually blocks T3 binding to the receptors. And what I have found is a lot of research that kind of shows that it doesn't block the T3 receptor. So when the cell brings T4 and T3 in, there's something called deiodinase enzymes, and it's these enzymes that then determine what happens to T4 and T3. So deiodinase 2 is the one that typically converts T4 to T3. Deiodinase 1 and deiodinase 3 are typically the deactivating forms of deiodonases. Okay, so the D1 and D3, the deactivators, are found in the plasma membrane. That's like right when the thyroid hormone comes in the cell, that's the plasma membrane, and those hormones are right there. So what it's believed and what the literature shows is that the deactivation actually occurs right at the plasma membrane, and then that reverse T3 is actually shunted right back out of the cell and shows up in your blood. The deiodinase 2 is closer to the nucleus. It's in something near what's called the endoplasmic reticulum, which is where that occurs. So it's like two different areas of the cell. It would be like saying that because I live in Pennsylvania and you live in Virginia, that we're going to be seeing each other all the time. It's too far of a travel point. So it is, based on all the literature I read, reverse T3 does not seem to block the T3 receptor. I think what's really happening is that cell is trying to downregulate the metabolism of the cell. It's deactivating that reverse T3, and because or it's deactivating the T4 to reverse T3, it's also deactivating the T3 that's coming into the cell to T2. And the reason you have hypothyroid symptoms is because there's that active hormone isn't occurring. We're getting more deactivation of hormone, and the receptors just aren't getting anything. And so when we see that reverse T3 in the blood, that's an indication that the cell's deactivating thyroid hormone, not necessarily that that's the reverse T3 that's blocking and causing the hypothyroid symptoms. I think the hypothyroid symptoms are occurring because there's just not enough active hormone getting to the receptor because it's getting deactivated.
So if you have increased reverse T3, can you reduce it by just switching, but mainly switching your medication, maybe taking a T4 only and switching to a T3, since that conversion is happening from T4 to the reverse T3, so it would makes sense that if you wanted to lower reverse T3, let's just switch you to a T3 so that it doesn't make it anymore. Is that what's your thought on that?
So I know there's a lot of people thinking about that in functional medicine and saying, hey, if you have a high reverse T3 and the high reverse T3 is blocking the T3 receptor and causing you to have hypothyroid symptoms, if we just switch your medication from T4 to T3, then reverse T3 will drop and your symptoms will be restored, right? Because you won't have that reverse T3 to block the T3. The T3 will just get right to the receptor. The reality is that yes, your reverse T3 will drop because you don't have T4 to actually convert to reverse T3. But we're talking about the deactivation of thyroid hormone, right? And so if you don't provide sufficient levels of T4, then reverse T3 will drop because the substrate to make the reverse T3 is not available. Yep. But the T3 is going to come into the cell. The cell is still in deactivation mode, so that T3 is still going to get deactivated to T2, but we don't measure that. Yep. So you're still potentially going to have the hypothyroid symptoms because the same process that was causing the deactivation of T4 to reverse T3 is still going on in the cell. The T3 is being deactivated T2. The thyroid receptor is still not getting T3. You're still going to have hypothyroid symptoms. Your doctor may be happy because reverse T3 dropped, but you may not feel better, and you probably won't feel better.
And I mean, it's that seems almost like a Band-Aid. I mean, you're not fixing the underlying reason that you were making more reverse T3 in the first place. So, just shunting it somewhere else and just putting a Band-Aid on it is kind of like if your check engine light came on your car and you just put a piece of tape over it. You're not seeing it on the surface anymore, but there's still something going on that needs to be addressed, which is ignored. And going back to the whole factor of whether reverse T3 actually blocks the receptor or not, you'll see on whether that's Facebook, Instagram, people sharing these posts over and over again. And I think we kind of get in a rut in functional medicine where we see oh, well, everybody thinks this way, so I should think that way too. And it kind of becomes this, well, that's just common knowledge. Everybody thinks that way, but we never sit back and question. And, looking at the research and what you've done, there really isn't much to back that up. And I think we just need to take a step back and actually, look at, whether that's really happening or not.
Yeah, we have to look at pathways and mechanics of how things are happening. And to your point, a lot of times somebody reads a post and they like that idea, and so they parrot what was in a post without actually doing the literature search or the research to find out, is that accurate? And that stuff gets just pushed through the blogosphere, and it may not actually be accurate. Yeah. I mean, we see that with a lot of things. I recently did a post on vitamin D and how everybody's deficient in vitamin D and we should just be giving everybody vitamin D. And the reality is, if everybody's deficient in vitamin D, then we're probably measuring something wrong.
Yeah.
Right? So, and so I won't bore us on this post or this podcast.
The whole podcast on the to D or not to D.
Right, so we did that one. Yeah, absolutely.
So that's up for people to go back and listen to that one. If you were told that your T3 is low and your reverse T3 is high, then should you take selenium?
So I hear this quite a bit. My T4 is not converting to T3. So that's what it looks like on my labs. So my doctor said if I take more selenium, since that's the cofactor for the deiodinase enzyme to convert T4 to T3, if I take more selenium, that should help with T4 to T3 conversion. Well, we go back to our original thought process here, and that is that that conversion of T4 to T3 is occurring in the cells. And the conversion of T4 to reverse T3 is happening in the cells, in a lot of those peripheral cells. So if there's decreased conversion, the selenium is utilized it's the cofactor for all the deiodinase enzymes. So if we have this deactivation process going on, the selenium is probably still going to support the deactivating enzymes versus the activating enzymes. Yeah. Okay, so I get the idea, but people have to remember the selenium is a cofactor for all three of the deiodinase enzymes, not just the one.
Yeah,
R3.
You really should be, you really, when it comes to any of the minerals or anything, you really should be, if you're deficient, that is the time when you maybe need to be supplementing with it. You shouldn't take that to force a pathway when unless you're deficient in selenium, I mean, there's no need to be taking that at that aspect too. I mean.
Right, and we're not typically measuring selenium, right? And we have to remember, even though there's a pathway we want to happen, just because we put more selenium into the system doesn't mean that that's the pathway what we want to happen is going to happen because we put more in, right? We see that all the time. Somebody says, I think this pathway is not working and that's a B6 dependent pathway, so I'm going to take more B6. Well, if the cells are using that B6 to do a different pathway and you load that B6 in, you may get a negative result, right? You may not feel good, right? And so the organism is pretty smart. The cells are their own like little network, their own organism, right? And so they're doing what's best for them. And so I think when we look at reverse T3 and we say, hey, the cells are causing this rise in reverse T3, we have to say maybe there's a reason for it, and maybe we shouldn't be trying to force chemistry that the cells are trying to not have happen.
Yeah. What actually causes reverse T3 to increase? Like, what are the driving factors for it?
Well, there's a lot of things that can drive it, but if we take a look at it, it is either this for some reason the cell is deactivating or wants to slow the metabolism down. Okay, so there's lots of things that could do it. It really comes down to stress, right? So if a cell has sufficient amount of energy, it's going to deactivate reverse T3, and I want to make sure there's always activation and deactivation occurring, right? It's when we see the rise in reverse T3 or the ratios of T3 to reverse T3 start to skew. Or you have somebody who's got chronic hypothyroid symptoms, then we want to take a look at those values, right? So the cell is always determining how much thyroid hormone it needs, and if there's a little bit more than it needs, then it deactivates it. So there's always some level. So you should always have some level of reverse T3. But overall, if we start to see reverse T3 levels rise, we have to consider that there's some type of stress occurring at the cellular level that's causing the cell to say, hey, there's a threat here, there's a stress, I want to slow the metabolism of the cell down. And in that situation, it could be a physical stress, falls, traumas, injuries, something that damages tissue, physically damages tissue. It could be emotional stress, right? If you're constantly in a worry state, that can create a stress response at the cellular level. It could be chemistry, right? Toxins, environmental toxins,
blood
EMFs,
sugar,
blood sugar. And then it could also be microbes, right? Bacteria, viruses, and you've got a background with, especially with Lyme disease.
Oh yeah, I mean that's one of the biggest things I see is, with reverse T3 going high, when it's really high, I'm always thinking, okay, there's some major thing going on inside the cell that may be driving this. And a lot of times it uncovers that maybe they've had a history of Lyme, or maybe they have Epstein-Barr, or maybe it's just, maybe there's other bacterial infections going on that you have to look at. So at the root of it, there's something that's driving that inflammation, and that's where you'd have to put on your clinical hat and really start to dive into, look at all the things, we've talked about this on every single podcast, is that there's some sort of cell danger response, there's some sort of stressor that's driving the physiology. We often, and I know you say this a lot, is that, the body doesn't make mistakes, there's a reason why it's happening, and so you can't, force it. You want to try to find what's causing it by addressing that. We often can get to those root sources, and then you don't have to worry about forcing reverse T3 down. It's going to resolve on its own. Yeah,
I think sometimes we make a mistake and we blame allopathic medicine for trying to force things into a normal range, and we have to be really careful in functional medicine that we're not doing the same thing, but just with vitamins, right? I think it's, you think about the things that might create it, and it could be just, the stress of what you're eating every day. It could be the lack of food that you're eating, or the excessive exercise you're doing that could create those issues. And one of the things that happens, and it's prevalent, really prevalent in society today, is many people don't breathe well. And especially at night, if you are a mouth breather and a snorer, you're not getting sufficient oxygen to your brain. You create hypoxia. That's where the whole sleep apnea thing comes in, why people need the CPAP, because they're not breathing appropriately. They stop breathing, it creates stress response. But hypoxia from poor breathing is associated with elevations of reverse T3. So if you think about it, one of the things that may be driving your chronic hypothyroid symptoms and your reverse T3 to elevate may be something that's so basic and simple, and that's just breathing improperly, right? So just snoring all night, not getting good air, good oxygen to your brain, that could be at the root. So you have to start to, when you see that elevated reverse T3, there's some type of stress going on. It's usually not one thing, it's usually a combination of things, but you have to work either, you got to break it down yourself, right? Unpack what's going on in your life, or you got to work with somebody like Dr. Erica or myself to help unpack, all right, what is creating my stress?
Because and sometimes it's the things you think you're doing to be healthy could be causing, maybe it's your over supplementation, maybe some of those supplements that you're taking are poor quality that are creating inflammation, maybe some of the foods you're eating that you think are healthy are not as healthy as you think, or maybe it's the over exercise. People are overweight, tired, and fatigued, and they think if they just push through it, and they exercise more, that's
excessive,
and that sometimes drives that increase of reverse T3 because it's really trying to slow you down. I mean, that's
it's trying to, and especially from a food standpoint, when you think about it, hey, I'm just going to starve myself, and maybe that'll help me lose weight. If you reduce food intake for an extended period of time, to reduce calorie load for an extended period of time, you're sending a signal to your cells to say, hey, there's not enough food here. And if you were in a starved state, do you want your metabolism to be high or do you want it to be low? You want it to really be low so that you can survive on low levels of food, right? So you got to be really cautious when you see that value up, that we're just not trying to play physiologic whack-a-mole and whack it down. And if somebody's saying, oh, we're just going to switch your medications to lower it, and now that you understand that, T3 will cause it to go lower, it's because you don't have T4, but you do need T4 in the system. It's critically important.
Yeah, and I think the next kind of question that leads into this, with you have a high reverse T3, what can we do to lower it? You can go down the whack-a-mole and just try to do it by not fixing the underlying mechanism, but I think what we're trying to let people know is that you want to find what's truly causing it. That's how you're ultimately going to lower it and keep it there. Absolutely.
I mean, if you're an endurance athlete and you're training in your 50s like you did in your 20s and you're not allowing proper rest and recovery, that exhaustive exercise could still be one of the things that's driving up your reverse T3. And so it's a warning signal, right, to tell us, hey, that there's a problem going on here. But the key is definitely, if you want to lower your reverse T3, you've got to start looking at what are the stressors that are going on in my life that I can reduce or manage better. And you'll probably start to see reverse T3 go down. And it can get really complex. We talked about iron physiology can play a huge role in it, bacteria, viruses, and it gets complex. I mean, sometimes we make this sound simple, but the complexity of what's driving somebody's thyroid hormone to become deactivated and create their chronic hypothyroid symptoms can be a complex thing to try and address and fix. But definitely there's things that you can work on in your life. You can just take a look at your daily life and daily activities, and if you can't see what's creating the stress in your life, then you definitely need to work with somebody outside just you to really start looking at it and go, because it may be really obvious to you or I what's driving it, but if it's your life and your lifestyle, you may say, but this is my normal life and lifestyle, and so this couldn't be it, but it can be.
And one simple thing that people often overlook is emotional health. I actually had a patient, I think it was like a year ago, we had done everything functional medicine wise. She was, she still had some thyroid symptoms, and her reverse T3 was always elevated, no matter what we did to try to combat the pathogens and the adrenals and all that stuff. And I started diving more into the stress, and she currently didn't have any stress in her life, but when we dived into her history, she had been sexually abused as a child. She had gone through divorces. She had lost a lot of people in her life, and as we talked about, you could see she was getting very emotional about it, and I encouraged her to go to a therapist and maybe talk through some of those things. She came back 6 months later, and we actually ran that test, and it was low. And so I think maybe her dealing with some of her past stuff maybe still was weighing on her that she didn't even realize. So there's always things that may not be currently happening, maybe in the past that you have to look at too. You have to look at your skeletons in the closet sometimes too.
Yeah, I think we pack those things away and we hope I'll just ignore it. But it perseverates. It still can create issues and stressors for people. And I think you got to be aware of every aspect of what could be having an impact. Sometimes we look at the easy, obvious stuff like my food, my fitness, my lifestyle a little bit, but really mindset is huge.
Oh, yeah,
I mean, the person we talk to the most in any given day is ourselves, right?
Yeah.
And so if you're busy beating yourself up subconsciously, that's you are maybe your biggest enemy, right? And that's the biggest thing you have to overcome. There's a lot of things we can help you with from a dietary, gut health, supplementally, but we can't really out-supplement a bad mind, a bad thought process.
I agree, 100%. All right, last question. Can reverse T3 be too low?
Absolutely. Yeah. So somebody would say, if my reverse T3 is really low, so is that a big deal? And the answer to that is maybe, right? And the answer is, if you have chronic hypothyroid symptoms and your reverse T3 is low, then we still have to say, well, something's creating that symptomatology, right? So we have to go then and take a look at T4. And if T4 levels are low, then T4 is what actually converts into reverse T3. So if your T4 levels are low, that's the substrate, the thing that has to convert to reverse T3. If T4 is low, then reverse T3 is going to be low. So we don't want to just look at reverse T3. We want to look at all the markers, T4, T3, kind of see what they all look like. And so when people tell me my reverse T3 is in the normal range, but I still have all this symptomatology, I want to go back and look at, okay, but what's your T4? Your T4 is actually low, so that's our problem. You don't have enough T4. Right?
They also may be on a T3 only medication too.
Could be on a T3 only medication, and nobody may have ever looked at, if they only ran TSH and your TSH was normal, nobody may have ever looked at that, because the only reason more than TSH ever typically gets run is when your doctor looks at your TSH and it's high, right? Or it's really, really low. They'll take a look at maybe the rest of the panel. But if your TSH is in normal range, nobody's looking at the rest of those values unless you're doing functional medicine. I just had an interesting case the other day of a patient whose TSH is I think it's like 0.3 or 0.02, so it's really low TSH. And her doctor is thrilled because she's overweight. She's lost 60 pounds or so since we've been working with her. And so the doctor's like, but she's tired, fatigued, and she does any muscle activity, her arms burn. She's not, her metabolism is really compromised. Her tissues aren't making fuel appropriately, so she exhausts and fatigues and get muscle pain with exertion. So like the metabolism is not working. Her doctor has her on a T4 medication, and her doctor is saying your TSH is low, so the thyroid values are fine. The problem is the doctor's not looking at T4. So she is on she's on T4 med. Her T4, when I ran the full panel, her T4 I think was around 4, which is lab low. And her reverse T3 is in the upper 20s. I think it may have been even pushing into the 30s.
Wow.
So in this situation, her doctor didn't look at the T4 to see it. She just saw that TSH came back in a normal range, so she assumed that everything was working fine. And what's really happening is she's not really on enough T4 to begin with to support her brain, which is one of the reasons she's got brain fog and brain symptoms. And because she's got this cellular stress going on, she's converting most of what she's taking into reverse T3, and that's why it's so high. The problem here in this situation for her was she is on blood pressure medication that causes the reduction of TSH. So now she's got two things that are dropping her TSH below levels. One is she's got chronic inflammation because we ran the inflammatory markers. That's suppressing her TSH production, and she's taking a blood pressure medication which is also causing the TSH to be too low. And I won't get into the chemistry of that, but you have to look at the whole panel. So when we look at thyroid panel, we want to look at reverse T3. If it's high, then we're automatically thinking there's some type of stress response. If it's normal range, Then we want to take a look at T3, reverse T3 ratio. I like to say if it's less than 10, then we've probably got cellular hypothyroidism. That's our term, tissue or cellular hypothyroidism. In some circles, they may call it euthyroid sickness syndrome or non-thyroidal illness syndrome. I don't really like those names because they really associate those names with people with severe disease. And I think those are really the only people that get reverse T3 run. Those people that are in severe illness. That's why they associate only with people in severe illness, because those are the only people that they're really testing it on. But we also want to take a look at free T3 to reverse T3 ratio, and if that ratio is less than 0.2, then again we would consider that there's this cellular hypothyroidism going on. I think this is a question we talked about before, and you might have had, is what is elevated reverse T3 always a problem, right?
It doesn't always have to be a problem. I had a patient come in was feeling great, but a reverse T3 was borderline. It was functionally high, and there becomes a point where you have to look at the patient's symptoms versus what their labs. I mean, the rest of her lab work was perfect. Everything else was in range. She doesn't have symptoms, so sometimes you have to take that with a grain of salt and look at the patient as a whole, and that doesn't necessarily mean that there's a problem. Maybe we want to keep an eye on it.
We just caught a moment in time, right?
Yeah.
So they could be somebody who was coming off a fast, right?
Yeah.
You got the reverse T3. It could be somebody who just did heavy endurance workout a couple days before. Could be somebody who started a ketogenic diet, right?
Yeah.
So there's a lot of factors that can cause it. So if you get blood work done, even by a functional medicine practitioner, which is where you're probably going to get reverse T3 run, and you feel great, but it's a little elevated, I really wouldn't worry about it, right? If everything else is good, your inflammatory markers are good, blood sugar regulation's good, I don't think you get freaked out about it. Now, if you start to see a pattern that each time you get it done, that it's elevated, and you start to see other markers start to come out of range, or you're starting to have more of those chronic hypothyroid symptoms, I would be a little bit more concerned about it. But remember, anytime we're doing blood work, it's a snapshot, right?
Is, yeah.
And so if the snapshot that we look at makes sense for the person that's sitting in front of us, then we want to take action. But if that snapshot is abnormal, but the patient is functioning well, I don't want to say necessarily we just base it on symptoms, because you could have insulin resistance and feel good, right? You could have cardiovascular disease and think you feel good, right? You could have magnesium deficiency and still think you feel good, because you don't necessarily know what better feels like. But if it's slightly elevated or elevated once, everything else seems good, then I probably wouldn't put as much stock in it. I'd say let's get it rerun in a couple months, see how you're doing.
I agree. All right. Well, I think that we have completely rounded the whole reverse T3 topic. I think we've given our listeners lots of information. Do you have anything else, last little tidbits you want to add?
Yeah, I think the last tidbits to add is, always make an effort to try and get the full thyroid panel done at a minimum. And we would say if you can, you want to get a comprehensive panel that includes a bunch of inflammatory markers as well. Because if you see other markers on your lab report that show inflammation, that kind of confirms why that reverse T3 is elevated. So tests like if your hemoglobin A1C is elevated, uric acid's elevated, you see your ferritin levels elevated, you see fibrinogen elevated, you see
C-reactive
protein, homocysteine. You see that you have a low vitamin D level, 25 OHD. That's a good indication too that you might have something going on. Matter of fact, we'll just tie that in. Make sure if you're getting 25 OHD, always get two other markers done. 125 OHD and RBC magnesium. You really need to have all three of those things done. But try and get as comprehensive blood panel with some of those inflammatory markers to go along with your thyroid panel. So that way, when somebody looks at that, they can say, okay, we have other markers of inflammation, not just one thing that's elevated. Okay?
Awesome.
So we're going to wrap this podcast up. If you have any questions regarding this podcast, put those questions below wherever you watch. If you have some topics that you want to discuss or have us answer any questions, reach out to Dr. Erica or myself at our offices via our emails or any of our contacts. You can also put those questions below wherever you watch the podcast, and we'll be sure to include those in here. If you need some help with thyroid help, you can reach out to Dr. Erica. She is at
brainandbodyhealthcenter.com, and you can find us on Facebook, Instagram. We have a YouTube channel as well.
Yep. And my office, we have a new name. It's Rejuvigen Center is the website, www.rejuvigencenter.com. The office is called Rejuvigen, Functional and Regenerative Medicine. And you can search me and find me on YouTube, Vimeo, Instagram now.
He's making a lot more posts on Instagram.
Making some good Instagram posts and Facebook. And do us a favor. If you like the podcast, go to iTunes or whatever it is called now and rate the podcast. Give us as glowing a remark as you feel is appropriate, and that'll keep us motivated.
We want to know that people are listening and enjoy this. It gives us motivation to find more people to interview, to do more podcasts. We want to know that people are actually enjoying this. So just, give us a rating or shoot us a comment or even send us an email of topics that you want us to talk about.
Absolutely. We got a bunch of guests coming up in the coming weeks, so stay tuned. All right?